Good afternoon. My name is Tom McDonald. I'm the Chief Operating Officer for Ultimate Rehab. Preparation for PDPM, or the patient-driven payment model, is at the top of our minds, and it's at the top of mind of anybody working in skilled nursing today. And so in preparation for that, we thought it'd be a good idea to have a conversation about how people are preparing for PDPM, as we're only a little over 100 days away from implementation. So today we have with us Tammy Cassidy, who is president of TL Cassidy and Associates, and Cheryl Marler, who is VP of Operations for Ultimate Rehab. So Tammy, let me start with you. What are you doing right now to help your clients prepare for PDPM?
Well, right now is the time for a lot of education, a lot of prep work, and a lot of strategy. Primarily what we're doing right now is really working with teams to first educate, especially the leadership teams and the MDS teams, make sure that they have a good knowledge of the PDPM process as a whole, and then also ICD-10 coding is a critical part, as those are the two key factors that will be an indicator of your rate, basically. But then also taking a deeper dive into that and looking at your other processes and starting to strategize about what makes the most sense for your individual group. So looking at the frontline team and making sure that they understand section GG and ADL coding, making sure that they understand depression scores, making sure that they understand the cognitive and the BIM scores, speech therapy comorbidities, so they know what to look for and how to communicate with each other. The other piece that's going to be critical is looking at things like your vendor contracts and making sure that you have the most successful partners to help you, whether that be therapy partners, MDS partners, or other vendors out there. And then finally, looking at the system as a whole. So what types of residents are you taking in right now? And what types of care are you providing, and what types of rates are you getting for that care? And then also looking at what you might be able to do in the future. So will you be able to take care of higher acuity? What would need to be done in order to help you take higher acuity? What will your rate look like if you take that different type of resident? So predicting what might happen come October 1st. Finally, just getting over that fear. So in 1997, because this is truly the biggest change that we've seen in the MDS world since 1997 when PPS came around, everyone was terrified. We thought that this was, going to be the end of us with PPS. It wasn't. We educated ourselves, we learned the system, and we survived. The same thing is going to be happening with PDPM. So really making sure that your teams are educated, make sure that your teams are communicating with each other, and being very honest about the additional support that they need, and then just developing strategies that will help your team come together and be successful.
Okay, great. Well, Cheryl, let me ask the same question of you. What is Ultimate Rehab currently doing to help their clients prepare for success under PDPM?
As a company, we've been very proactive in the preparation work that we've been doing to assist in the transition into PDPM for our clients. One area that we noted that we thought we could really assist them in was through the implementation of a speech screen. There are several areas of the MDS that really fall under the clinical expertise of the speech therapist. One of these areas is under section K, where you look at swallowing disorders and you look at nutritional approaches, such as if the patient is receiving tube feedings or is on a mechanically altered diet. Another area that falls under speech therapy is under section B. They ask the question if the patient is able to make themselves understood, and also are they able to understand the information being provided to them. And then finally, this allows the speech therapist to also do the brief interview of mental status, or the BIMS assessment, with each of the residents as they come in the building. So we're doing this with every skilled admission already that enters into each one of our facilities. In addition to that, we have developed a form, basically a Medicare aid communication form, that we are going to introduce to each of our clients. And this form is really designed to be an interactive forum among the entire interdisciplinary team. So we're going to bring this to your morning stand-up meeting, and in this form, there's all the pertinent information that's going to go into making sure that the MDS is completed thoroughly and accurately, such as ICD-10 coding, making sure that all the non-therapy ancillary comorbidities are included, the speech comorbidities, making sure all of that information is really included on this form, and that we're really discussing this as a team to make sure that the information we're providing is being provided in a timely and accurate manner. And then we also have developed clinical protocols. And in these clinical protocols, we've not just looked at diagnostic clinical protocols, we've also looked at developing protocols regarding what appropriately places a patient into either a specific group or a concurrent type of environment. So we've developed protocols around that, and we've started to educate our teams about that, because we're dealing with a generation of therapists that really haven't done a lot of group and concurrent therapy in the skilled nursing setting. So we really wanted to prepare them and start that educational process. Another area that we have really been looking at in great depth is our software provider allows us to import MDS information from each of our facilities into our software, and then it does a comparative analysis of where the patient falls from a RUG-4 standpoint versus where they're going to fall under a PDPM. And it looks at lots of characteristics, the diagnostic categories, but it also looks at a financial piece to allow us to really look at the financial impact that PDPM is going to have on our clients. So we've been sharing that information with our clients, as well as really trying to make some determinations about what we can do to support them in these areas.
Okay. And you going back to the comment you made about group and concurrent therapy, the rules under PDPM will allow for up to 25% of the minutes delivered to be done either under group or concurrent. So my question for you is, how much group and concurrent therapy do you think will actually occur within the facilities that you provide contract rehab services to?
I think it's important to remember that your treatment plan still has to be individually developed for each individual resident. So not every resident that comes into your building is going to be appropriate to be treated concurrently or to be treated within a group environment. So I think we need to consider that and consider the acuity level of the patients that are coming into skilled nursing facilities at this time. We've done research on this. We've looked at our current patient populations within our facility. I would believe that although 25% is allowable per discipline, I think more accurately, we're looking at probably between 12 to 18% of the therapy services for each individual therapy could be provided under a group or concurrent level, depending again on each individual facility and the types of patients that they're admitting into their facilities.
Okay, great. So Tammy, let me ask you, what are going to be the biggest changes for MDS nurses under PDPM, and what kind of things can therapy do to support them in the transition?
Well, really from an MDS perspective, their entire world is changing right now. So we're going from a system that has traditionally been very focused on therapy provision and therapy services to a system that now really looks at that resident as a whole person. We're looking at a much more holistic approach to the reimbursement and really taking credit for all of those other nursing comorbidities that resident might have versus just a therapy score. So from the nursing perspective, they're going to be focused much more on capturing all of those non-therapy ancillaries, capturing all of those comorbidities, and capturing them quickly because our assessments are also changing. And now instead of having multiple assessments to capture the resident services, we're only dealing with one assessment. So we have to gather all of that information accurately and very quickly to get it communicated onto the MDS. So from a therapy perspective, what's really going to be critical is that communication between the therapy department and the MDS department to make sure that we're capturing all of those subtle changes, to to make sure that if therapy is seeing something on their end that may be a non-therapy ancillary, that we can have clarified with the physician, that we can get that clarified and quickly get that onto the MDS. Another example of the collaboration would be in something like Section GG, which traditionally we're gathering a lot of that information from just the therapy department. Well, now we really need to focus much more critically on that section and gather the information from therapy, gather the information from nursing, combine that together and get a true and accurate picture of that resident. Finally, I think one of the other critical pieces would be just having therapy at the table during all of the strategy discussions. So recognizing that therapy needs to be a true member of that interdisciplinary team, and they need to be part of the team that's driving the education of the frontline team, driving the education and determining which residents we can care for and which residents we maybe need to enhance our education on before we take them in. So just that communication and that collaboration, that's going to be what's critical as far as how therapy can support the MDS team.
Okay, great. Cheryl, how does Ultimate Rehab currently work with MDS, and how do you think that will help them in the transition to provide the kind of support that Tammy's talking about?
The rehab team managers at Ultimate Rehab already work in a really strong partnership with the MDS nurses. We meet each day, and during those meetings, we discuss clinical findings. We discuss assessment reference dates. We discuss the therapy that's been provided for that patient and any barriers that we might be having with that resident. So we already really have established that strong working relationship. I think as we move forward, under PDPM, it's going to become even more crucial that we're communicating on a consistent basis. I think there's almost going to need to be a pretty continuous flow of information back and forth. And not just with the MDS nurse, I think the entire interdisciplinary team is really going to need to be involved in that process, really sharing any information that they have to bring to the table so that we can really most accurately capture the characteristics of each resident that we're serving. I think because we've already have this strong relationship established, that this really is going to be a fairly seamless transition for us. We're already doing the meetings. I think we're just going to have to shift the focus of those meetings, and what we're discussing in those meetings is going to have to be more focused on sharing the therapy that's provided and the barriers that we're having. We're going to have to really be, like Tammy talked about, what non-therapy ancillaries have we noted in the documentation that we've reviewed, or what are we seeing with that patient, and everybody really bringing a piece of the puzzle to the table when we're discussing these residents.
Okay, great. So Tammy, what roadblocks to success do you see out there that might prevent a skilled nursing facility from being successful under PDPM?
Well, I think the biggest roadblock would be basically denial at this point that PDPM is definitely coming. Come October 1st, we will be under PDPM rules. So now is the time to make sure that your entire team is educated and they're prepared for it. So if a team decides that they're going to wait and hold off on education until maybe August, September, they're really missing that opportunity to collaborate as a team, develop some strategies, and make sure that they have everything in place to be successful. So just for example, they need to use this time not only for the education, but look at every process that they have along the way. And not just MDS processes. Obviously, we need to look at what types of residents we can care for. We need to look at what the role of the MDS nurse and the role of the therapy director will be. We need to look at who is going to be responsible for which sections of gathering information and putting that on the MDS. But then also looking at rehospitalizations, length of stay, the admissions process as a whole, and then really talking to the frontline team again and saying which residents do you feel comfortable with and what type of services do you need a little bit of extra education on. That's what's going to be critical, is not waiting until the very end and hoping for the best. It's a process that you really need to strategize for and make sure you're prepared for.
Okay, great. Cheryl, let me end by asking you, what final words of advice would you have for people in terms of preparing for PDPM?
I'm probably going to reiterate a little bit about what Tammy said. I think the most important thing that you could be doing right now is educating your staff, educating the frontline teams as well as those that are sitting in these meetings. You really need your frontline to have an understanding of PDPM and the impact that it's going to have. So I think that that's really where we need to start, and I don't think that we can wait until October 1st to do this. I really think the education needs to start now, and we need to move forward and be able to smoothly transition into PDPM.
Great. Well, I want to thank both of you for your time. I really appreciate it and your insights. And if you don't mind, we'd like to do this again over the next couple of months and provide continued updates and information and advice.
Thanks, that's good.
Great.
Thank you.
Thank you.